Welcome to our first video on diseases of the heart muscle. Let's begin. In this lecture, we'll discuss dilated cardiomyopathy and restrictive cardiomyopathy. For each condition, we're going to talk about its definition, pathophysiology, causes, clinical presentation, diagnosis, and management. Let's start with dilated cardiomyopathy. Dilated cardiomyopathy, as the name implies, is the progressive dilation of the heart leading to systolic dysfunction. In other words, dilated cardiomyopathy leads to heart failure with reduced ejection fraction. Dilated cardiomyopathy is caused by eccentric hypertrophy of the myocardium. Eccentric hypertrophy means that sarcomeres are added to each other in series. This leads to global heart dilation, which in turn leads to decreased contractility. Let's take a closer look at this idea with an illustration. Here's an illustration of sarcomere changes associated with the two general types of myocardial hypertrophy, concentric hypertrophy on the left and eccentric hypertrophy on the right. Note that in concentric hypertrophy, the sarcomeres are added in parallel and the size of heart chambers like the right ventricle or the left ventricle gets smaller. In eccentric hypertrophy, on the other hand, the sarcomeres are added in series, which leads to enlargement or dilation of the heart chambers. Excessive dilation, in turn, impairs the heart's ability to contract, which means a reduction in myocardial contractility and thus cardiac output. This is the change that occurs in dilated cardiomyopathy. We will revisit this illustration later in the presentation when we discuss hypertrophic obstructive cardiomyopathy. Dilated cardiomyopathy is most commonly idiopathic. However, it can be inherited due to an autosomal dominant mutation in the TTN gene, which codes for a sarcomeric protein known as titin. Patients with history of chronic alcohol ingestion or chronic cocaine use may also develop dilated cardiomyopathy because alcohol can exert direct toxic effects on myocardium, and chronic cocaine use results in sympathetic overstimulation of the heart, which eventually leads to myocardial fatigue and dilation. Patients with wet beriberi are also at risk for developing dilated cardiomyopathy. Recall that wet beriberi is caused by a deficiency of thiamine, which plays a crucial role in production of ATP. As such, in patients with wet beriberi, thiamine deficiency results in low myocardial ATP levels, and therefore low myocardial contractility, which over time may result in dilated cardiomyopathy. Doxorubicin is a chemotherapeutic drug known to exert irreversible toxic effects on myocardium and decrease myocardial contractility. This is in contrast to trastuzumab, another chemotherapeutic drug which exerts reversible toxic effects on myocardium. Therefore, discontinuation of trastuzumab may result in some improvement in myocardial function. Chagas disease is a protozoal infection caused by Trypanosoma cruzi. This protozoan is known to cause dilation of the heart by infecting and weakening the myocardium. Myocarditis can eventually lead to global heart dilation due to inflammation of the myocardium. We will talk about myocarditis in detail later in this lecture. Thyrotoxicosis causes sympathetic overstimulation of the heart, leading to myocardial fatigue and dilation. Finally, peripartum cardiomyopathy develops when the myocardium of a pregnant woman cannot tolerate the normal pregnancy-associated increase in blood volume. This is an illustration of a sarcomere with its components. Please note that familial dilated cardiomyopathy is caused by an autosomal dominant mutation in the TTN gene that codes for titin. As you can see in this illustration, titin acts as the scaffolding protein for the myosin filaments. We will revisit this illustration when we discuss the hypertrophic obstructive cardiomyopathy later on. A 57-year-old woman comes to the physician due to shortness of breath when she lies down. Her past medical history includes breast cancer treated with trastuzumab. She is in remission and she does not take chemotherapy anymore. She has been drinking 1 bottle of wine daily for the last 20 years. Physical exam reveals peripheral edema and jugular venous distension. What is the most likely underlying cause of this patient's current condition? This patient presents with orthopnea, which is shortness of breath that gets worse in a supine position. Orthopnea is a sign of left-sided heart failure. She also has peripheral edema and jugular venous distension, suggesting concomitant right-sided heart failure. These findings, along with her history of alcohol use and trastuzumab intake, should raise suspicion for dilated cardiomyopathy. She used to take trastuzumab, which is known to cause reversible dilated cardiomyopathy. Since she does not take trastuzumab anymore, it's unlikely that her heart failure is due to the chemotherapeutic drug. This patient has been drinking 1 bottle of wine daily for the last 20 years. Hence, the long-term heavy alcohol use is the most likely underlying cause of her dilated cardiomyopathy. Let's talk about the clinical presentation of dilated cardiomyopathy. Since this condition causes both left and right-sided dilation of the heart, the patients will have symptoms of both left-sided and right-sided heart failure. Left-sided heart failure presents with dyspnea due to pulmonary edema. Additionally, orthopnea is characteristic of left-sided heart failure. Orthopnea is a term that describes worsening shortness of breath when lying supine. This happens because lying supine increases the venous return to the heart. This in turn increases the volume of blood pumped by the right ventricle into the lungs. In healthy patients, the left heart works well and is able to drain the excess fluid from the lungs by pumping it forward to the rest of the body. In patients with left-sided heart failure, however, the left ventricle struggles to pump blood forward, which means that fluid builds up in the lungs and leads to worsening dyspnea. Paroxysmal nocturnal dyspnea occurs when a patient with heart failure wakes up at night gasping for air. Once again, this occurs because fluid builds up in the lungs when the patients lie on their back, and the left heart struggles to drain the lungs by pumping blood forward. Eventually, enough fluid builds up in the lungs to cause dyspnea severe enough to wake the patient up. Let's move on to the symptoms of right-sided heart failure. The general principle is that fluid backs up behind the failed right ventricle. Backflow of blood from the right ventricle into the superior vena cava, brachiocephalic veins, and internal jugular veins results in jugular venous distension. Additionally, fluid backs up in the inferior vena cava and hepatic veins, resulting in congestive hepatopathy, potentially hepatomegaly, and a positive hepatojugular reflux. This is where the examiner pushes on the patient's liver and observes elevation of jugular venous pressure for several seconds. Hepatojugular reflux indicates that right ventricle is already volume overloaded and cannot accept more blood. So the blood from the liver goes up in the jugular veins when the pressure is applied. Finally, patients with right-sided heart failure also have peripheral edema due to backflow of blood and fluid transitation from vessels in the extremities. This is an illustration comparing a normal heart on the left and a heart with dilated cardiomyopathy on the right. Please notice the dilated left and right ventricles and normal myocardial wall thickness on the right-sided image of the heart. Here we see the signs of right-sided heart failure. The external and internal jugular veins become congested so that when a patient is supine, there will be signs of jugular venous distension. As blood travels back into the inferior vena cava, congestion in the hepatic vein may result in hepatomegaly that can be seen in these patients. Finally, fluid will continue to back up and eventually reach the lower extremities through the external iliac veins, causing peripheral pitting edema. Here you see an image of jugular venous distension on a patient. Note the rope-like distended vein. Here's an image showing pedal edema. Note that the edema is pitting, indicating fluid transitation from increased hydrostatic pressure, secondary to fluid buildup in the veins of the lower extremities. The physical exam is important to support the diagnosis of heart failure. Heart auscultation may reveal an S3 heart sound, which is a sign of volume overload. Lung auscultation, on the other hand, may show bilateral crackles and decreased breath sounds due to pulmonary edema. Lung crackles are most audible at the lung bases, since this is where the fluid tends to accumulate when the patient is in upright position. One will also be able to observe the peripheral pitting edema. Jugular venous distension and hepatomegaly, with a positive hepatojugular reflux, indicate fluid accumulation in the systemic veins in the setting of the right heart failure, which we have discussed in detail on previous slides. In case of suspected dilated cardiomyopathy, we should consider the patient's history with associated risk factors like alcohol ingestion, cocaine use, and so on. Let's talk about the echocardiography findings of dilated cardiomyopathy. As implied by the name, dilated cardiomyopathy, echocardiography shows global heart dilation. Ejection fraction is typically less than 40%. Left ventricular wall thickness is normal because dilated cardiomyopathy is not due to concentric myocardial hypertrophy. Finally, left ventricular filling pressure is increased due to volume overload. Here you can see how dilated cardiomyopathy appears on echocardiography. Please note the dilated left ventricle and left atrium. Let's move on to the management of dilated cardiomyopathy. First, we should treat the underlying cause of dilated cardiomyopathy. Severe cases are treated with heart transplantation. Additionally, we should treat the heart failure that is a result of dilated cardiomyopathy with medications like ACE inhibitors, beta blockers, and diuretics. A 72-year-old man comes to the physician reporting swelling of his feet for the last 6 months. He's been drinking 1 bottle of wine daily for the past 40 years. Physical exam reveals peripheral pitting edema and the jugular venous distension. Echocardiography reveals an ejection fraction of 30% with global heart dilation. What is most likely to reverse this patient's condition? This patient presents with peripheral pitting edema and jugular venous distension. Echocardiography reveals an ejection fraction of 30% with global heart dilation. This description is consistent with dilated cardiomyopathy. He has been drinking 1 bottle of wine daily for the last 40 years. Therefore, this patient likely has alcoholic cardiomyopathy. Complete alcohol cessation is most likely to reverse the alcoholic cardiomyopathy. Let's move on to restrictive cardiomyopathy, which is also known as infiltrative cardiomyopathy. Restrictive cardiomyopathy is characterized by progressive myocardial thickening that leads to diastolic dysfunction. In other words, restrictive cardiomyopathy leads to heart failure with preserved ejection fraction, or HFrEF. Restrictive cardiomyopathy can be idiopathic. It can also be caused by infiltrative diseases like sarcoidosis, storage diseases like hemochromatosis, and endomyocardial fibrosis. The common pathophysiology behind these 3 diseases causing restrictive cardiomyopathy is that a non-muscle substance infiltrates the myocardium. The substance can be a variety of things, such as amyloid in amyloidosis or iron in hemochromatosis. This leads to rigid and non-compliant myocardium. Therefore, diastolic ventricular filling decreases because ventricles can no longer accommodate normal amount of blood. Causes of restrictive cardiomyopathy can be remembered by the mnemonic, please help. P stands for post-radiation fibrosis. When the patient receives chest radiation, this can induce myocardial fibrosis. Loeffler endocarditis is associated with hypereosinophilic syndrome and is due to eosinophilic infiltrates in the myocardium. Endocardial fibroelastosis, the most common cause of restrictive cardiomyopathy in children, is due to fibrous and elastic tissue deposition in the endomyocardium. Amyloidosis causes amyloid deposition in the cardiac muscle, making it rigid and non-compliant. Sarcoidosis is associated with myocardial deposition of non-caseating granulomas. Finally, hemochromatosis causes iron deposition in multiple organs, including the heart. A 58-year-old woman comes to the physician due to worsening shortness of breath for the past year. Her past medical history includes mediastinal non-Hodgkin lymphoma treated with radiotherapy. The physical exam reveals 3+ peripheral pitting edema and jugular venous distension. Echocardiography shows an ejection fraction of 65%. What is the most likely underlying cause of this patient's current condition? This patient presents with shortness of breath, peripheral pitting edema, and jugular venous distension. Shortness of breath indicates backup of blood into the lungs, which occurs in left ventricular failure. Pitting edema and the jugular venous distension, on the other hand, indicate the right ventricular failure. Therefore, this patient has biventricular heart failure. Her ejection fraction is normal. Therefore, she has heart failure with preserved ejection fraction. Considering that she was treated with radiotherapy for mediastinal non-Hodgkin lymphoma, she likely developed restrictive cardiomyopathy due to post-radiation fibrosis. Physical exam is also important to support the diagnosis of restrictive cardiomyopathy. Heart auscultation will reveal an S4 heart sound, which is a sign of ventricular noncompliance. Lung auscultation, on the other hand, will show bilateral crackles and decreased breath sound due to pulmonary edema. One will also be able to observe peripheral pitting edema. In case of suspected restricted cardiomyopathy, we should consider the patient's history with associated conditions like post-radiation fibrosis, amyloidosis, sarcoidosis, and so on. Electrocardiography, ECG, in a patient with restrictive cardiomyopathy will show low-voltage QRS complexes due to non-muscle substance interfering with signal reflection on ECG leads. Echocardiography typically shows the hypertrophied ventricles with decreased compliance. One can also perform a myocardial biopsy to investigate for infiltrative diseases. Pink amorphous material on the myocardial biopsy specimen indicates amyloidosis, while non-caseating granulomas indicate sarcoidosis. This is an ECG showing low-voltage QRS complexes, which can be seen in restrictive cardiomyopathy. Please note these abnormally small QRS waves that occur due to non-muscle substance interfering with signal reflection. Here you see a myocardial biopsy specimen taken from a patient with amyloidosis. Please note this light pink amorphous hyaline material in between cardiac myocytes. This is what amyloid looks like on histopathology. Here is a myocardial biopsy specimen taken from a patient with sarcoidosis. Please note this mass composed of multinucleated giant cells and the eosinophilic histiocytes. This mass is consistent with non-caseating granulomas. The term non-caseating refers to the absence of caseous necrosis in the center of the granuloma. In patients with restrictive cardiomyopathy secondary to sarcoidosis, this finding can be seen in biopsies of heart muscle. How can dilated and restrictive cardiomyopathy be differentiated on echocardiography? Echocardiography typically shows dilated chambers and a low ejection fraction in dilated cardiomyopathy. In contrast, it shows small chambers and a normal ejection fraction in restrictive cardiomyopathy. The mainstay of management for restrictive cardiomyopathy is treating the underlying condition. Additionally, one should treat the manifestations of heart failure, such as fluid overload. Refractory cases of restrictive cardiomyopathy are treated with heart transplantation. Here's a table summarizing all the conditions we discussed in the lecture. Please pause the video and take a moment to consider this table. A 49-year-old woman comes to the physician due to shortness of breath and bilateral leg swelling for the last 3 months. She has a 20-year history of rheumatoid arthritis treated with methotrexate. Her vital signs include a temperature of 37 degrees Celsius, blood pressure of 135/85, heart rate of 87, and respiratory rate of 18. Physical exam reveals jugular venous distension and 2+ bilateral pitting edema in the lower extremities. An S4 heart sound is heard on cardiac auscultation. ECG reveals low-voltage QRS complexes. Echocardiography shows an ejection fraction of 60%. Myocardial biopsy reveals pink amorphous material with Congo red stain positivity and apple green birefringence under polarized microscopy. Which of the following is the most likely cause of this patient's current complaints. A. Loeffler endocarditis, B. Amyloidosis, C. Sarcoidosis, or D. Hemochromatosis. This woman presents with shortness of breath and bilateral leg swelling for the last 3 months. She has a 20-year history of rheumatoid arthritis treated with methotrexate. The physical exam reveals jugular venous distension and 2+ bilateral pitting edema in the lower extremities. These signs indicate right heart dysfunction. S4 heart sound is heard on cardiac auscultation, suggesting ventricular noncompliance. ECG reveals low voltage QRS complexes. Low voltage ECG, in this case, likely signifies a substance deposition in the myocardium. Echocardiography shows a normal ejection fraction of 60%. Considering all these findings, the patient has restrictive cardiomyopathy. Myocardial biopsy reveals pink amorphous material with Congo red stain positivity and apple green birefringence under polarized microscopy. These latter clues are classic for amyloidosis. This patient likely has secondary amyloidosis due to rheumatoid arthritis-induced chronic inflammation. Therefore, the correct answer is option B. Here's a slide reminding us of the causes of restrictive cardiomyopathy. Pause the video and take a moment to consider the slide again. Now let's discuss why other options are incorrect. Option A is incorrect because although Loeffler endocarditis can cause restrictive cardiomyopathy, it is characterized by eosinophilic infiltrate on the myocardial biopsy. Option C is incorrect because although sarcoidosis can lead to restrictive cardiomyopathy, it typically shows non-caseating granulomas on the biopsy. Finally, option D is incorrect because although hemochromatosis can lead to restrictive cardiomyopathy, it usually reveals Prussian blue positive intracellular iron deposits. And that concludes our lecture on dilated and restrictive cardiomyopathy.